Uh, Hello, everyone. Thank you for joining today's medical grand rounds. It's my pleasure to introduce to you our relatively recent colleague, Nassir Marrouche, who is an internationally renowned electrophysiologist and a pioneer in the treatment of atrial fibrillation. He is a tenured professor of medicine in the Division of Cardiovascular Medicine, and he is the director of the electrophysiology division here. He initiated a collaborative arrhythmia center that is bringing together a cross-departmental team of physicians, scientists, researchers, MRI and imaging specialists dedicated to working collaboratively to innovatively improve successful prediction, prevention, and outcomes in the treatment of cardiovascular disease. Dr. Marrouche also founded the University of Utah's Comprehensive Arrhythmia Research and Management Center, known also with the acronym CARMA, leading a team of researchers conducting highly innovative research on using MRIs to treat atrial fibrillation. Dr. Marrouche received his medical degree from the University of Heidelberg, Germany. He completed his residency in internal medicine and cardiology at Klinikum Coburg, the teaching hospital of the University of Würzburg. He then completed clinical clerkships at the Cleveland Clinic Foundation, Harvard Medical School, University of Bristol, and University of Washington Medical Center. He then proceeded to complete fellowships at the University of California, San Francisco, and the Cleveland Clinic Foundation. Dr. Marrouche is a fellow of the American College of Cardiology and Heart Rhythm Society. He has published more than 200 peer-reviewed articles in prominent medical journals, including the New England Journal of Medicine, Circulation, and the Journal of American Medical Association, JAMA. I want to remind the participants that we're expecting that there will be some time for Q&A, and there is a Q&A bubble at the lower part of your screen, which you may bring up by toggling your pointer at the lower part of your screen, and type your questions there, and I will read them to Dr. Marrouche upon completion of his presentation. It's all yours now, Dr. Marrouche. Thank you for agreeing to present today.
Thank you, Ravici. Hello, everybody, and it's my great pleasure and honor to talk to you as my colleagues here at Tulane. And I wish I could be in person with you in a lecture room, but obviously the pandemic has pushed us to be apart, and I will talk to you via Zoom. I want to share with you today as what I've been practically working on for the last 28 years of my life or career. Latest update on atrial fibrillation management. There's a lot happened specifically in the last 3 years in the management of atrial fibrillation as we know it. And I thought this is important to get an update to my internal medicine colleagues and the people who deal with these patients every day and in their life in their clinics. Let me start with this. An electrophysiologist who treats AFib showing you a CT scan of the brain as his first slide. And you ask yourself why. Unfortunately, this is why. Stroke. Obviously, you don't need a radiologist, a neuroradiologist to read this. This is a patient who experienced a stroke, a massive stroke, embolic stroke, as you see in this CT scan. If you look in this patient appendage, there was a clot, and this rhythm was AFib. This same patient, we saw him a year ago, was in sinus rhythm, came to see us for checkup. He did everything right. Normal stress test, normal echo had nothing, and suddenly shows up with stroke. And that's the story we deal with in our careers, treating arrhythmias and AFib and the consequences of AFib. As I showed you, major consequences of this disease, which is stroke, and why we're trying day by day to find preventative ideas and treat these patients as early as possible before they come to these consequences. So I want to tackle 4 topics today. Quick review on AFib and the numbers. The case for rhythm control, why rhythm control becoming more and more essential in terms of treating patients with AFib, treating atrial fibrillation in a sick heart, patient with heart failure, and show you what we're doing briefly here at Tulane, our Tulane concepts that we're presenting here to the world. Atrial fibrillation, as one of our colleagues here at Triad called it, the ticking bomb. Dr. Delger put this slide together. It's an epidemic. 37 million people and increasing worldwide. 70% increase expected in the next 20, 30 years. This is important. And this is really crucially important. Imagine 5% incidence of heart failure, stroke, MI, or cardiovascular mortality per year due to AFib. As important as this is an amazing number that people doesn't like to talk about. I don't know why. But fact is, a patient with AFib, she or he would have 35 to 50% chance of going to the hospital, being admitted, or even dying from consequences of AFib within 5 years. So it's time to not underestimate that disease. Briefly, this slide summarizes what AFib was about. I tried to find as simple explanation as I could. Electrical impulse disorganization within the left atrium that trigger irregularities within your lower chamber response you see in the slide here. Irregularity in the upper chamber that goes down to irregular response seen in AFib on this slide. This is AFib. So everything we're trying to do, we kind of shut down these irregularities here, trying to cure AFib. But what we learned over the years, especially the last 15 years, it's a substrate. It's a myopathy of the atrium that triggers all these issues or diseases, all the chaotic impulses that cause AFib. We know that atrial myopathy leads to remodeling and fibrosis, like you've seen on this MRI scan. Green is fibrosis and white is fibrosis or disease. The blue is healthy tissue. And what this causes is more triggers beyond the pulmonary veins that we know about that causes AFib and trigger AFib. And this leads to AFib. And the dysfunction itself, if you look at the dysfunction of the caused by the myopathy, leads to blood stasis. And as you know, we're getting closer to Virchow's trias, that causes a stroke. So that's a story behind the myopathy that we know about more and more. So it's more than the irregularities that we're dealing with actually in patients with atrial fibrillation. So that's relationship here, myopathy, keep this in mind, either to AFib, to stroke, and so on. When we treat atrial fibrillation, we have two goals to achieve. Number one, improving quality of life of our patients due to the symptoms. Still, up to 40% of patients with AFib, and maybe more now with the devices and the tools we have on our wrists, we're detecting more asymptomatic AFib. There's a lot of patients with asymptomatic AFib. The goal of treating AFib, the second main goal for us as treating physicians or providers, is to prevent morbidity and mortality associated with AFib. When we see a patient with AFib, when you see him today in your clinic or when you leave this talk or tomorrow in the ER, you immediately think of two approaches. One is the rate controlling the patient, like in this case, slowing their heart rate down to let them feel better. And this is done by calcium channel blockers, beta blockers, or digoxin, or rhythm control using an antiarrhythmic drug or cardioversion or an ablation procedure. So these are our options, and they're all available to us today. I want to focus today, and due to recent publications the last 12 months to 24 months, on ablation as a treatment option. I'll show you why. But before I go further, AFib ablation, how we ablate AFib, is we try to isolate the triggers, what we call it the pulmonary vein isolation. Look at this example here. This is the atrium. These gray structures here are the pulmonary veins, bringing the blood to the heart, but they also bring triggers. We knew this in 1998, they trigger extra beats that goes into these arrows and trigger AFib. What we do during AFib ablation, we go into this atrium and we do lines, ablation lines around the veins, as you see here. What we do with this, we achieve isolating these triggers, not allowing them to go out and initiate the chaotic rhythm of AFib. That simplified the AFib ablation. And usually this is an example, a patient, the groin stick, femoral vein, we go up to the heart, up to the atrium, you see the catheter here, through the septum, transseptal puncture, and we do the ablation left atrium. So that's an AFib ablation or pulmonary vein isolation. Let's go back to your clinic. I'm in the clinic now, and you're seeing a patient, 55-year-old male, hypertension on ACE, complaining of episodes of palpitation. This is his 12-lead ECG, turned out to be AFib. Now we ask ourselves, what are the treatment options to manage this patient? Should we give him beta blocker for rate control? Should we ablate him? Antiarrhythmic drugs? Schedule electrocardioversion? Or just wait, it's just the first episode? So all options, if you take any of them today, until maybe I would say 2 months ago was okay, but since 10 months ago, 2-3 months ago, I'm not sure that's okay anymore, and I'm going to show you why. Another patient, 62-year-old female, medical history of diabetes, hypertension, heart failure, ejection fraction of 32%. Her AFib was diagnosed 2 years ago. She's on amiodarone. Again, this is her ECG, wide QRS complex. What's next for this patient? And again, you can debate to choose one of these options. Antiarrhythmic drug, continue the amiodarone and shock her, do an ablation, do a bi-V ICD or defibrillator and bi-V pacing, add digoxin, or continue treatment monitoring. Until a couple of months ago or years ago, there was normal to choose any of those, but today, ablation is the way to go, and I'll show you data why. And this is again going back to the guidelines. You continue updating them every 6 months now, because the treatment option is various. And that key here for you that the rate control strategy was assumed for asymptomatic patient, and it's not the case anymore. We can't just assume rate control anymore, and I want to show you why we need to pursue rhythm control. And the case for rhythm control as we speak. So since 2000, we've been dealing with randomized trials comparing rhythm control using pharmacological drugs, antiarrhythmic drugs like flecainide, propafenone, sotalol, or amiodarone versus rate control strategy with beta blocker, calcium agonist, and digoxin. And all these studies you see, look at them here, have the same, except the last one here on the left lower side, looked at rhythm-based rate control using drugs, including patient post-open heart surgery. And all of them showed practically no difference. Let me start with the AFFIRM trial, which all of you know by now, published in 2002. And AFFIRM compared the biggest study ever to be done, compared AFib rhythm control strategy using antiarrhythmic drugs versus rate control with beta blocker and digoxin and calcium antagonists. And they found no difference in mortality. And any study after that, like the RACE trial published in New England Journal of Medicine, same year, same issue actually, showed no difference in outcome in terms of mortality, hospitalization, and side effects. So until now, rhythm control using drugs was the same as rate control, and the option was left up to you. All these trials mentioned here, PF, STAF, the Gilnow from Cleveland Clinic, and Hot Cafe, all of them looked the same thing, and they found no difference in outcome, rate, or rhythm control using antiarrhythmics. But until we realized that we're looking at the AFib, and this is really one of our work here and in Utah for the last 12 years, looking at the myopathy itself, as I showed you before. Until we realized we're treating patient maybe later, we looking at the patient all in the same box. The earlier you look at the myopathy, like this is an example, best example of this patient, only a year later, after AFib was diagnosed, his progression of myopathy increased from 6% to 31%. So I think we've been dealing with AFib when we see them in our clinics and we're treating them, we're waiting too long to treat these patients. Target early, treat early before disease is too advanced. And I show you results from the EAST AFNet 4 trial, which has been published in New England Journal of Medicine just last September. This is a very important trial because they took patients with new onset or less than 12 months diagnosed atrial fibrillation. 2,789 patients randomized to rhythm control strategy using antiarrhythmics or ablation versus usual care mean rate control strategy. They looked at mortality, strokes, and MIs and admission for heart failure. And this is an important slide because in this trial, in contrary to affirm, 20% of patients had ablation strategy as a rhythm control, not only. And we have a lot of dronedarone, which is a new antiarrhythmic used to maintain rhythm control. And the rate control strategy, most of the patients, they maintained rate control without using rhythm control. When they use rhythm control, they use ablation. So this is to mention, just for you to know that the rate control was really followed as per protocol. 2 years follow-up. This is important. The median days since AFib diagnosis was only 36 days in this trial. Keep in mind, treating early, 36 days. In 38% of patients, first episode of AFib was diagnosed for the study. Asymptomatic AFibs were 30% of the population in this trial. That means we're mostly asymptomatic, 70% at 2 years. If you look at the outcome of the study, rhythm control strategy that I just described led to 22% relative risk reduction in mortality, strokes, hospitalization, and so on, compared to rate control. That's a game changer. Early intervention. And if you look at the reason why this happened, is really cardiovascular deaths was improved and strokes were improved with the new NSAID strategy. And to summarize this, to the study, you know, all of you listening to me today, they know the AFFIRM trial very well. To summarize and compare to ESAF, and what changed? Early intervention, ablation was added as strategy to treat this patient, anticoagulation was persistent across the board and not stopped, and dronedarone was drug used in 20% of patients. So this is 4 major difference what changed in the last 20 years since AFFIRM that I think contributed to success and patient living longer, having less stroke and going less to the hospital. Early rhythm control with ablation and drugs, specifically dronedarone, seems to lower risk cardiovascular outcomes. So what's next? If you ask me now, okay, Marrouche, you're talking about rhythm control. Is it drugs or is it ablation? I showed you data trying to highlight that the 20% patient undergoing ablation made a difference here. Let me go further. We know for a while now that this is a great study by Dr. Lundquist, Corina from Sweden, who showed in a prospective fashion randomized patient and looked at ablation versus medication in terms of quality of life. And she found a significant improvement in quality of life in JAMA paper 2019. Cabana trial showed a difference only in cardiovascular mortality and hospitalization in terms of improvement with an ablation procedure. That's very important. Yes, we have the endpoint was not a significant difference, but if we look at cardiovascular mortality and hospitalization alone, ablation was superior to antiarrhythmics or drugs in general. The STOP-AF trial, and this is actually 2 trials published in New England Journal of Medicine just a couple of weeks ago, back to back, looking at ablation versus drugs in terms of early treating AFib. It's called the STOP-AF trial, early antiarrhythmic drug or ablation as first line. So patients with early onset AFib, the first AFib episode, they randomized them ablation versus drugs. And they showed that the ablation was superior. And you see the numbers here, 74% versus 45%. The LAAF trial, ablations versus antiarrhythmic drugs, in this trial, they put the loop recorders, they implanted the monitor inside the people's bodies, continuous monitoring, and they found ablation to be superior to drugs with a relative rate reduction of 52%. 2 studies in New England Journal of Medicine last couple of weeks, again, backing up the idea that ablation is the way to go to improve AFib, connecting the dots with the early or the ESAF trial, early intervention with an ablation is superior to antiarrhythmic drugs in hopefully preventing outcomes, hard to endpoint outcomes. Now let's talk about treating patients with sick hearts, with LV dysfunction or myopathies. We know the atrial remodeling and AFib and heart failure is very well intertwined. 38% of patients with heart failure have AFib, 40% patients with AFib heart failure. We know that. Increased mortality with AFib and heart failure, we know that. Increased stroke risk, we know that. But if you look at the physiology, the decreased compliance of the atrial pump due to AFib leads to heart failure, and vice versa, the increased pressure in the atrium of heart failure leads to AFib and myopathy and so on. AF also increases with symptoms, and that's important for you when you see a patient with heart failure. The earlier the symptoms, the less incidence of AFib, the more sicker they get, the higher risk of having AFib. Actually, up to 50% or more if they are class 4 or 3 or 4 or higher. How we treat these patients, we tried, and this is a major trial in 2008 published in New England Journal of Medicine, where they did rhythm control versus rate control using antiarrhythmics, amiodarone, or rate control with beta blockers, digoxin, calcium antagonists. No difference in worsening heart failure, no difference in strokes, or no difference in mortality and strokes or heart failure altogether. So we knew from 2008 on there wasn't a difference if you use drugs to improve outcomes in patients with AFib heart failure. We do this with dofetilide, ticosine. We did the same study, Diamond HF trial. We found no difference in New England Journal paper 1999. Myself, my partners, and Professor Bachmann from Germany, we conducted this trial called the Castle AF trial, where we took patients with LV dysfunction, sick hearts, EF less than 35%, multi-center trial, randomized them to ablation versus conventional treatment in terms of using antiarrhythmics or rate control strategy, and looked at outcomes. Inclusion criteria of patient with AFib, any kind of AFib, patient who failed drug or intolerant to drug or did not want to take drugs, and as I said, sick hearts or EF less than 35%. The primary and composite endpoint of this trial, and this paper published in New England Journal of Medicine 2018, we showed that with an ablation procedure, we can lower the risk of mortality and hospitalization of heart failure by 38%. We also showed if you take ablation of all-cause mortality alone, ablation was superior to drugs by relative risk reduction of 47%. Ablation also led to 44% reduction in heart failure admission. So in sick hearts, and this has been reproduced by now by a couple of other studies or trials, ablation is superior to drugs in improving outcomes. We also learned, and this is so crucial and important, I can't talk enough about this, early intervention. Do it before it's too late. You see the AFib, you act on it. That's another example from the Castle AF trial, sub-analysis. Patients of early New York Heart Class 1 or 2 of the disease, early symptoms of the disease, they did way better than patients who have advanced symptoms, as you can tell from this slide. 66% of the catheter ablation patients have the EF even improved to more than 35% with a normal range almost. We kept the sinus rhythm maintained for a longer period of time. This is the red bars. These are the patient on an AFib. This is from their defibrillators because they have monitors on their chest. So we could tell every single beat over 5 years, and you can tell you can keep sinus rhythm longer. Why this is important? Because we showed in the same trial, if the patient rhythm AFib burden is down by 50 or 40%, you helping your patient to live longer and to stay away from the hospital. So it's all these crucial information we collected the last 2 years. Early intervention in terms of heart failure symptoms, in terms of AFib diagnosis, and lowering the burden of AFib is so crucial. We also learned from Castle, from the group that did not have an ablation, that the drugs, antiarrhythmics or rate control, rhythm rate control with drugs, did not make any difference. In heart failure population, antiarrhythmic drugs did not help. That's what the bottom line in Castle. Only ablation improved outcome. And I'm so happy and honored to say that our study at Castle AF led to change in the guidelines to make ablation heart failure patients a 2A indication. That's a recent guidelines published in September of this year. Exploring fluid directives, what we're doing in the future uncurrently here at Tulane. We call it the Tulane approach for AFib management, personalizing AFib management. Obviously, there's a lot been going on digital health at Tulane. We and computer science and epidemiology and biomedical engineering, we've been putting infrastructure to target people rhythm early on, understand the behavior before it's too late in AFib. But as important is understanding the myopathy. This is our MRI concept that we brought to Tulane. So we image our patients before we see them, before we treat them, understand how much myopathy they have, and based on that we act. So again, this image is made out of MRIs, and again, green and white is myopathy, blue is healthy. And why this is important, we showed this in a JAMA paper in 2014 and randomized or prospective follow-up study, that the more myopathy the patient have, the stage 4 patient or 3, they don't do as well in terms of treatment compared to early stages. So the earlier we treat the patient, we see them, the better they do in terms of AFib recurrence. And we also learn with time that treating this myopathy or ablating this myopathy seems to help this patient as well. Ablating, treating myopathy, that's what we're doing at Tulane. We also learned that this myopathy is a major, major stroke risk in our patients and heart failure as well. A paper we published in JACC in 2017. So all coming together, and this has been implemented at Tulane. If you look at these two patients, does our concept, our hypothesis of treating these patients by only ablating or isolating triggers or treating the substrate as well, like seen here, does this make a difference? And that's a study that Tulane has been leading worldwide today as we speak at 44 sites, Europe, Australia, and United States, called the DCAP2 trial. We finished recruiting, we reported data in March, and hopefully this will be major, major changes in the way we treat AFib based on looking at the myopathy. And hopefully I can share the data with you. We're following patients with mobile health. We're looking at two strategies, as I said, one is MRI based and one's regularly. But this will redefine the way we treat AFib, hopefully, but keep in mind as early as possible. Can we slow down fibrosis, myopic progression? This is the work we've been doing here at Tulane as well. We think this myopathy is the key. The earlier we intervene, we slow it down, the more we prevent AFib, and the more we care our patients. We have data that dronedarone, the antiarrhythmic, is capable of slowing progression of the myopathy in the patient's heart. This is a small study that we conducted. We took this now, a multi-center trial. We're starting this as we speak at Tulane. The EDORA trial that Dr. Dager has been leading with us here. Randomizing patients to dronedarone versus control after an ablation procedure to allow the myopathy for a short period of time, for at least a year after the ablation, to understand it, slowing down inflammation and suppressing myopathy. We're following patients with digital health tool, and this will help us a lot to understand how is the myopathy affecting patient after treatment of AFib. To summarize, our approach at Tulane has always been, we take the fibrosis, as I said, and we treat the patient based on the fibrosis. So we assess the risk of not only for ablation, but risk of stroke based on the myopathy as well. And that's important. If we have patient have recurrences of arrhythmia, we treat them based on these images, and this is a standard of care. These myopathy images means a lot, and that's the trigger of treat AFib today. To go back and try to summarize what we try to share with you today, and the number one message I want to communicate to you today, due to recent data from us and others, early rhythm control, specifically using ablation, seems to improve outcomes, mortality, hospitalization, and beyond. Especially in heart failure population, this patient profit a lot in terms of living longer, staying away from a hospital by intervening early and ablating the AFib early. Thank you. Open for questions.
Thank you. Thank you, Dr. Marrouche. We have a good amount of time for a Q&A session. I want to remind participants to type their questions. Let me start with one question, and I'm thinking of a patient of mine in the clinic. Is a 60-some-odd-year-old gentleman, early 60s, has no major health condition other than what we call essential hypertension, which I don't know what it is, but nevertheless, he's being treated for that. But I noticed that his baseline heart rates were high. So I referred him to a cardiologist. We're working by telemedicine because of distance. And the cardiologist, his local cardiologist, diagnosed atrial fibrillation on him. He's completely asymptomatic. He wasn't even aware that he had rapid heart rate. It just, they were 100, 110 a few times from his automated blood pressure machine. So my question is, would ablation be considered potentially preemptive and perhaps the better treatment, even though now he's currently on a beta blocker? I don't know if he converted to Sinus, but his rhythm rate controlled. So I think we see quite a number of patients like this. What would be your recommendation based on this excellent work you presented?
Yes, early intervention in this patient, and this is what the goal of my talk today, Richie, is early intervention with an ablation procedure in this patient will help him, based on the data we just saw, not only improve his outcomes in terms of mortality and hospitalization, but also quality of life and beyond. And I want to really highlight the fact that patient we see a lot in the clinic. We call them asymptomatic, but if we dig more, we dig deeper, there's always something there. They call it aging. They call it, I can't do 3 trees a day in my garden. I do 2.5. They call it, I'm getting old. AFib has some consequences. There's obvious symptoms and there's little symptoms. So any AFib, and this is really the message today, and as I said, until maybe 8 months ago, I would say this patient, let's assess his MRI scans and look at his myopathy. I will still look at his myopathy, by the way. He may have a lot of myopathy and allow us to treat him. But this patient needs to be intervened on as early as possible to prevent him from consequences. And as I showed you from outcomes, will save him a lot of hassle going down the road. The data is supportive, is powerful in terms of helping him. And these are the patients need to be treated as soon as possible with an intervention procedure.
Good. Thank you for that answer. We have several questions. Let me start with Dr. Schamberger's. How often is it necessary to do repeat ablation after having the procedure previously?
So, I showed you that the slide, Dr. Schamberger, from our approach here at Tulane. And that slide is important to I'm not sure if I can share my screen still or not. Let me try. Because that's important for everybody. Let's see if I can go back. Yes, can you see my screen, guys?
We don't see it.
Let me see it, because I wanna answer this with a slide. Can you see it now?
Yeah, now we can see it.
Okay, so this slide here, sorry, this one here. I have long presentation, so that's great. And so here, stop signature, share screen.
We no longer view.
Can you see it now? Okay. Let's put the slide on. Okay. Okay. This slide here. So if you look at the slide here, Schamberger, so this is what I call the redo ablations, redo procedure. And you can tell from here, when we do an ablation procedure, we try to fight with this myopathy. Until now, and this is what we do at Tulane, by the way, it's maybe 30, 40 sites worldwide are taking our approach now, because we need to look before we treat. Even with redos, If a patient comes to see me after redo procedure, have recurrence of AFib, and have an image like this one, where you have a lot of myopathy, new myopathy, plus the lesions from the previous procedure, I'm not sure I can help that patient much. But if the patient comes to see me with this kind of little myopathy, or little myopathy like this one, little lesions, that there is a lot for me to go in and fix. So that's why this whole MRI imaging concept, understanding myopathy, what we're treating with. I mean, if you go anywhere in the world, they take the patient again and again and again to the lab. I will not disagree with all people if we have a target. But today's world, in today's world at Tulane at least, we assess the myopathy, where to ablate before we go in, and assess our strategy. That's why it's important. It's not a yes and no, how many procedures I can do. What's the target look like going back in? So it could be only twice, it could be 4 times. If I see targets to help my patient, I continue going in to fix it. And that's key because we think about the disease, Dr. Schomburger, that it stops. We ablate it and it stops. That's not true. We ablate it, but there's progression. That's why the IDORA trial, we're trying to find tools to suppress this progression. It's something we can do beyond ablation. So looking is helping us a lot, and personalizing the approach for the redo procedure is helping us better define these patients.
Okay, thank you. Another question is, if a patient has long-standing AFib with dilation of the left atrium, would you try ablation or less benefit in this case?
Sure, we try ablation if the MRI, again, come to this image. I'm not sure you still see my screen, but if the image shows me, and by the way, this myopathy does not follow dilatation. Dilatation, if it's like a balloon, you put water, it dilates, inflated dilates. It doesn't mean that the balloon rubber is bad. So it's key is to understand what the myopathy looks like. And long-standing AFib expression has been overused over years. And actually our societies are trying to abandon this expression. By the way, these images are now in the guidelines, in AFib guidelines. They recommending looking at the myopathy as we treat them. The one published in ESC in September, using MRI scan, because this expression of long-standing AFib, long-time AFib, you get surprised how different the hearts are. So I would treat that patient with ablation. Yes, if, by the way, this patient will have 70% chance that his atrium is one of the eligible for ablation, I would image them, look at them, and give them a shot, sure.
Thank you. Another question is, when you do rhythm control for AFib, do you need to anticoagulate the patient?
Yes, that's important. That's really important. And that's the one thing that has been, I would say, standardized across the globe now with the use of NOACs. And that's, we have some data now, actually, in fact, we just submitted an NIH grant we have a lot of data showing that this myopathy and the shape of this atrium, very powerful predictor for strokes. We are applying this here. If somebody have a little myopathy and have a shape of the appendage, not too long, shorter, small osteoid appendage, these are criteria we use them today at Tulane to help us deciding the blood thinners long-term, independent from the CHA2DS2-VASc score, by the way, or the CHA2DS2-VASc of 0 and 1. If they have a very bad myopathy with CHA2DS2-VASc 0 and 1, or the atrium is, the shape is spherical shape, or the appendage is long, we tend to give them blood thinners. But yes, rhythm control will make an indication personalized based on the patient structure and functionality of the left atrium. We factor this in if we want to stop it or we continue it.
Thank you. Couple more questions from Sai Nedunchajian. What, in your opinion, is the ablation trial we need most now?
Yeah, I think the ablation trial we need the most now is understanding the Castle AF2. We did Castle AF1 and there's a Castle AF2 heart failure population. We have more and more that this sick hearts, we know that they profit and they live longer if you ablate them, but if you look at the data, there's still 40% patients who don't respond to treatment from ablation. And ideally is to find prospective, and actually in the process of designing that trial, prospective randomized based on a myopathy image like this one, randomized heart failure patients with sick hearts and disease hearts, how much structure in the heart disease, how much scar in the heart they have, in the ventricle because of MI and beyond, and randomize them based on these findings to a procedure versus none, and see who lives longer on that. I think these personalized approaches are very important in terms of ablation procedure to better risk stratify and select our patient for these treatments.
Right. Another question, again, from Sai Nedunchazian. With regards to the ADORA, what do you hope to see with the dronedarone, given that it was shown to increase heart failure mortality in a clinical study previously?
You know, that's why this is a population we're using ADORA is normal hearts. We're not looking at the 20% AFib, we're looking at the 80% of the AFib population, or actually 70% at normal heart. That's what we focus on. So it's not the same population. Dronedarone will help us, and we're excited to see if we, and optimistic that we help suppression of that progression, like you see in this slide I'm showing. Hopefully we can prevent this from happening here, that residual of the new fibrotic areas. If we can prevent it, that's a major, major breakthrough after ablation with that drug, and hopefully we'll succeed doing so. But not heart failure population, we're using the normal heart population.
Thank you. Looking at any more questions? You can type them in the Q&A box. And I don't see any further questions. With that, I would like to thank Dr. Marrouche for sharing this exciting, groundbreaking work with us, and all of you for joining today's Grand Round. Have a wonderful afternoon and a safe afternoon, everybody. Thank you. Thank you, Dr. Marrouche.
Thank you. Thank you, Ichi. Thank you.